Here, can you hear me?
Hello, can you hear us? It's a pleasure to have you with us.
What an ovation. Wonderful.
Shall we go on with the questions straight away?
Yes, please.
So the first question we have for you really is, could you tell us a little bit about yourself and how you became interested in neurology?
Of course. So I'm Bloem. I'm the director of the Parkinson Center of Excellence in Radboud University Medical Center in Nijmegen in the Netherlands. It's a very large center with lots of PhD students. We've got 6 dedicated consultants focused on Parkinson's disease. It's a really wonderful, wonderful group. And I have the privilege of directing them. I got interested in neurology because my mom had multiple sclerosis. And my parents always used to say, your first word was mommy, your second word was daddy, your third word was neurologist. And I literally dedicated my life to becoming not only a doctor, but to become a neurologist in the hope of one day curing my mom and cracking the mystery of multiple sclerosis. And in the 3rd year of my medical school, I did some MS research, and I asked my supervisor if he could somehow arrange a trainee spot in the United States. And lo and behold, that very week, Professor Bill Langston was in Leiden, where I was trained at the time. And he, of course, was the discoverer of the MPTP Parkinson's, you know, the frozen addicts, the people who injected themselves with a self-synthesized heroin analog and developed Parkinson's almost within 24 hours. And that was a golden opportunity. I switched to Parkinson's, just pure coincidence. And from day one, when I started to work with people with Parkinson's, I was really grasped by the disease, by its complexity, its enormous variation between people, by the tremendous resilience, the admirable resilience of patients and families of how they cope with the disease. And from day one, I forgot MS. I switched to Parkinson's and it's never left me.
Well, we're very pleased you did. So secondly, you won't have heard Omatola's opening remarks, but she was saying that a lot more men are involved in clinical trials and research than women. And she wanted to ask if this puts women at a disadvantage in terms of treatment.
Yes, well, first of all, I think it's, can I say the word? It's a bloody shame that the trials are not well balanced. So there is a significant and relevant difference in the proportion of women who enter clinical trials as compared to real life. So, and we may come to this in a minute, but there are more men than there are women with Parkinson's. But there are way more men in trials than there are men in real life. And there are a number of reasons. One reason is that, for example, in my Center of Excellence, we see close to 70%, 70 men, which is nowhere near the real reflection in real life, which is closer to maybe 56% men, 44% women. And my explanation is that when a woman gets sick, she looks after herself. When a man gets sick, the wife makes sure that the husband goes to a university medical center and sees a top-notch expert. So women with Parkinson's are underserved in the world. I think that's a bold statement, but I dare to make that statement. And because women tend to attend university clinics less frequently, they're also less frequently recruited for trials. And also women just have greater obligations, I think, in life than men. Fact of the matter is, we see too few women in trials, which means that the studies based upon which we register our medication, we register drugs, we register surgical treatments, are not a fair representation of the real world, which means there could be missed adverse effects or missed wanted effects in women in these studies, so that women don't get the full benefit in daily life. And just to give you an example of a field outside Parkinson's, but it's a problem that's not unique to Parkinson's. There have been studies in cardiology where medication was registered based on work done exclusively in men, or almost exclusively in men, and then it was sold on the market to women who developed adverse effects, which were obviously not seen in trials because there were not enough women, and who developed sometimes fatal side effects. So I think trials should have a fair representation of both men and women, and we need to actively work on that, because daily life treatment is based on those trials. And so it's not fair.
So basically all us women really should be doing whatever trials we can and helping in that way going forward, if we can.
Yeah, so two things, Omotola. It's making sure, people enter trials and find the time in their busy lives with all their social obligations.
Yeah.
But also make sure you get the best possible care. I think my frank opinion is, and I'm saying this with the deepest respect for my colleagues working in general hospitals, but Parkinson's is such a terribly complex disease that I strongly believe that each patient with Parkinson's deserves at least once in their lives a visit to a real Parkinson expert who's dedicated his or her life to that specific condition. And more likely, or even better, is an episodic review by an expert. So you can stay with your general neurologist in your nearby hospital, but just as like you send your car for a periodic review to the garage to see if everything's still okay, I think Parkinson patients deserve their annual or biannual review by an expert. And women are not receiving that care today. So it's a call to all the women listening, make sure you get the best possible care.
Okay.
That was my Siri picking up information.
We just have a quick question from the audience. Is that okay with you?
Sure.
Just to follow up. Can you hear that? Or
No, I didn't hear the question. Could you repeat it?
sorry, the lady. Sorry, I think. Yeah. We're just getting one mic. Thank you.
Sorry, I just wanted to ask whether the fact that women are underrepresented is maybe a condition to do with their risk aversion, that in the same way as at university men get more first-class degrees and third-class degrees and women get second-class degrees, is it the same thing that women are more risk averse and don't want to take part in trials?
I think that's a very good point. All I can say is what the data are showing, and I gave you one of, no doubt, a long list of possible explanations, and I think yours is a very good one. You're a woman, so maybe you know better than I do, and I've only come to learn about gender issues in recent times when we discovered this unbalance in clinical trials and also the unbalance in our own clinical center. The risk aversity may be another explanation for this. I can also tell you that the more technical the trial, for example, wearable sensors or deep brain stimulation, the greater the imbalance. So women are even less likely to enter technical studies than they are in less technical studies. So maybe that's also a difference between men and women. Men may be more interested in technology, who knows? But I think the risk aversity is another factor that's definitely contributing.
That's lovely. Thank you. We'll move on to another question, otherwise we won't get through them all. But we've had a question online from Rebecca Potter, and Katie Hall has also asked a very similar question. So it's quite a long one, but it's basically in your movement disorder paper, which you published in 2015, you lean towards exercise as making a huge difference to symptoms. Are there specific sports that are better for keeping symptoms minimal? And what other factors can slow down progression of Parkinson's? And is there anything that's key, a specific slow down progression for women?
Yeah. So let me start with the second sub-question first. Despite everything you may read on the internet and claims that are sometimes being made, there is today no proven intervention, unfortunately, that can slow down, let alone arrest the progression of Parkinson's. Nothing. The good news, though, for everybody here in the audience and also listening through the internet, is there's a lot of hope. There are new interventions underway, which we feel may, with time, begin to slow down, maybe arrest the progression of Parkinson's. One of the most promising ones, to my mind, is exercise. There is preclinical work in rodents to suggest that exercise could have a disease-modifying effect. To prove that this is the case in humans is horrendously difficult. I can tell you that we've just completed an exercise study in people with Parkinson's who were asked to exercise 3 times a week at home on a stationary bicycle for 30 minutes. And that gave a tremendous clinical benefit. But the cool thing is that we also did brain scans before and after the exercise intervention. And you could see beneficial adaptative changes in the brain of people with Parkinson's who were exercising regularly. This is the first time that's been shown in human beings. So that's very provocative and very encouraging information. That's still not to say that exercise is disease modifying. It's a symptomatic treatment. I think there is good evidence now that regular exercise helps to suppress the symptoms of Parkinson's just like a drug. To prove scientifically that it modifies the course of the disease is very difficult. There's good work from Harvard Medical School to show that regular exercise before Parkinson's leads to a lower risk of developing the disease later on. So that's maybe already a hint that exercise is maybe also doing something at the etiological level, or the causal level. But to prove it is difficult. So exercise is promising, and everybody listening should regularly exercise. And in regards to the first question, is it a specific exercise? For all we know, it's likely the aerobic component. So bringing your heart rate up and making you breathe faster. And my rule of thumb is do something every day, not just 3 times a week, but every day. And why every day? Then there is no ifs, ands, or buts. You have to do it every day. If you do it 3 times a week, there's always tomorrow. You have to do it every day. Adjusting it to your heart rate tends to be difficult in people with Parkinson's because they have a difficulty increasing their heart rate. That's part of their autonomic failure. So I tell my patients, do something that makes you breathe faster, but still be able to maintain a conversation. That's enough, and do that for 30 minutes every day. You will experience symptomatic improvement of your motor symptoms. Probably your slow bowel movements will improve. Your sleep is likely to improve. And who knows, it may modify the course of your disease. And I don't think, sorry, and one thing, the final question is, and I don't think that effect is specific for men or women. I think both genders will benefit. There may be differences, and maybe we need to look into it. I don't think any research project has looked into it. I think it's safe to say that both men and women will improve from regular exercise.
The next question, so for me, Nicola Boo, and he asked, why do more men pass hormone hold a key? I mean, this might be also something to do with the fact that maybe more men can affect it, like we were talking about earlier. You know, with the clinical trials, it could be a similar.
Yeah. So that is a very interesting question, and definitely people have been speculating, and I'm actually personally convinced that hormones play a role in the manifestations of Parkinson's. So women tend to develop Parkinson's less frequently. They tend to develop Parkinson's at a slightly higher age. They tend to have more residual dopamine in their brain, as shown by dopamine scans at the time of diagnosis. And women tend to develop the tremor-dominant form of Parkinson's more frequently than men. And we know that having a lot of tremor is prognostically a good sign. So those are 4 factors favoring women having Parkinson's over men. So hormones might play a protective role or a modifying role in the lead up to developing Parkinson's. And people have taken this to the test with hormone therapies, trying to see if this could be used as a treatment for Parkinson's. And those trials have been negative. So once you have Parkinson's, providing hormones is too late. And of course, hormonal therapy has also risks for uterus cancer, breast cancer. So hormone treatments don't come for free. So hormones appear to play a role in the lead up to what later becomes Parkinson's. I think once you have the disease, hormone therapy is probably too late. And I just wanted to add that because women tend to develop Parkinson's less frequently and at a higher age, and because it tends to be more tremor dominant, many people, including me, used to think Parkinson's was more benign in women. The opposite appears to be true. If you look at Parkinson's in the long term, women have a range of disadvantages. Less access to care. They are less likely to get deep brain stimulation, for example. They tend to develop more dyskinesias and other cumbersome problems. So women have an advantage early on in PD, but in the later stages, women are at a disadvantage. I think that's important to say. So the common belief that Parkinson's is more benign in women is simply incorrect.
We've kind of covered question 5. It was to do with age ranges and progressive. If a different age group progresses differently, and if it affects men and women in a different way. So I guess we've kind of touched on that. Question 6 is from myself and I guess everybody else in this room, really. Do you foresee a cure in your lifetime? And if so, what capacity do you think this would be?
Yeah, just a quick thing about the age. We haven't touched upon age. I think quick things about age. One is, again, it's a misconception that Parkinson's is a disease of exclusively elderly people. It's an age-related disease, so it tends to be more common with aging. So the risk of an 80-year-old developing Parkinson's is significantly greater than a 70-year-old and then a 60-year-old, etc. But what is it? 10% is younger than 50 when they develop the disease. Maybe 5% is under 40. The youngest patient I've seen was 13 at the time when she had Parkinson's. So I think it's a complete misconception that Parkinson's is a disease of exclusively elderly people. I think we should really make every effort to put Parkinson's down as a disease that hits people right in the middle of an active life when they're making other plans, and then you develop Parkinson's. I think that's one thing I wanted to make.
Yeah, I definitely know that from my own experience.
You know that very well, unfortunately. And fortunately, the disease tends to develop at a slower pace in younger people compared to older people. So when you are hit by the disease at a younger age, you're obviously at a disadvantage, but the disease tends to develop at large a little bit slower in younger people than in older people, which probably has to do with the fact that elderly people have less brain reserve, have maybe comorbid conditions. So Parkinson's is more aggressive at a later onset than it is at a younger onset.
Yeah. So
people are partially compensated for that. So that's a little bit about the aging factor.
Okay. And then the question was
the cure.
If you foresee a cure, yeah.
Yeah. So I'll make a very honest statement about that. And the honest statement is I'm hopeful. But let's peel it down to what I think is realistic. First of all, I think my task as a physician, and I've really dedicated and committed my life to helping people with Parkinson's, is to be honest and to provide hope, but not to provide false hope. And that I think one of the toughest things for me as a physician is that fine line between hope and hype, and between hope and excessive hope. I hope you understand what I'm trying to say.
Yeah.
I think in my lifetime, I can disclose here, it'll be on YouTube, it'll be everywhere. I'm 52 years old. In my active lifetime, I expect to see that we can slow down the progression of Parkinson's in my active career. And if we can slow down the progression, and if we can develop the tools to detect Parkinson's at a much earlier stage, and there's wonderful work being done right now by Ron Postema and Daniela Berg, in particular on identifying the preclinical stages of Parkinson's, then you could maybe delay the onset of Parkinson's in those at risk, or maybe even prevent the disease. And if those disease-modifying treatments would potentially become extremely effective, we could maybe arrest the progression. I think slowing down, delaying, is something that I hope I will see in my active career. The other thing that I will expect to be able to see in my lifetime is much better symptomatic treatments. You know, with our Dutch Parkinson net, we've been able to now improve the care for people affected today with better physio, better OT, better speech and language, better nurses. The reality is Parkinson's is the fastest growing neurological condition on the planet, which means that there will be millions of people, extra millions of people, who deserve better treatment today. And I hope that every person affected around the globe in my lifetime will at least have access to the good symptomatic treatments that we have today. Not just the pills, not just the surgery, but it includes the multidisciplinary treatments. And then there is hope with stem cells. As you may know, the stem cell trials have been halted because of unexpected side effects, but under the leadership of people such as Professor Roger Barker in Cambridge, there are now new initiatives to again take stem cells to the test. And I think there's good hope that in my lifetime, stem cells and other restorative methods will come to clinical practice, again, in my lifetime. Stem cells and other similar types of treatments are not a cure. They are a clever way of bringing a little dopamine factory into your brain, which will provide symptomatic relief. Who knows, maybe spectacular symptomatic relief. We also know by wonderful work by Jeff Kordauer in America that these grafts are then attacked by the underlying disease process. So you're not cured of Parkinson's. A stem cell is not a cure for Parkinson's. It's an effective way of delivering dopaminergic treatment right within the brain. But I think that provides hope for people. Finding the real cure, and that's two things. Curing people who already have the disease, I think, is a long way to go. Because we tend to diagnose people at a very late stage when already a lot of damage has been done. Yeah. So stem cells may be able to reverse some of the problems, but I think a complete cure for those already with the disease, I'm very fair and honest about it, I think that's not realistic. But if the disease-modifying treatments, and there are many now on the horizon, are really effective, and if we can detect the disease early, there is some hope that we may be able to start preventing the disease in future generations. Yeah. And then one final thing, if I may, is there's a task there for pharma to build these drugs. There's also a role for societies, for governments, because one of the reasons we're now seeing this Parkinson pandemic, again, Parkinson's is the fastest growing neurological condition on the planet. And the reason is aging. It's maybe better ascertainment. We are better at identifying PD, but there's also, we think, a big role for environmental pollution. Pesticides, trichloroethylene, heavy metals, and the like. So there is a role for societies to protect laborers from exposure, to clean the environment, to eradicate the use of pesticides, to eradicate the use of trichloroethylene, to cleanse contaminated sites across the globe. And there's also a role, and that will also help partially to dam the tide of Parkinson's. So that's a long answer to a short question, but I know it's the burning question. And I hope that people will distill from my long answer that there is reason for hope, but it should be realistic hope. And I hope I've made myself sufficiently clear.
Yeah, cool. Sorry, there's just one lady who wants to ask another question in the audience.
I can't hear anything.
Sorry, we're just switching the
Hi,
microphone.
I'm Lisa, and I was diagnosed at 37. I'm now coming up 10 years having the condition. I just wondered what your outtake of the genetic side of Parkinson's disease would be. My granddad was diagnosed with it, and obviously I've now got the condition. I just wondered what my children's future might be.
Yeah.
Question, and one I'd actually quite like to know myself, because I've got 2 young children too.
Yes. No, that's a very good question. So when I started my career in Parkinson's, you were a loser as a scientist if you were studying the genetics of Parkinson's. Right now, we know that there are at least 10, 12 genetic factors that can lead to what we call Parkinson's disease in people. So Parkinson's disease actually doesn't exist. It isn't one disease. There are many genes that can lead to Parkinson's, and there are other reasons to develop Parkinson's, which are non-genetic. And then there are genetic factors that by themselves are not sufficient to cause Parkinson's, but that may predispose you to become more susceptible to, for example, the pesticides or the heavy metals, because not everybody exposed to pesticides develops Parkinson's. So yes, genes play a huge role in Parkinson's. It plays a role in particular when people are affected at a young age, which you appear to be. At least you look very young to me on the camera. Otherwise, take it as a compliment. And it tends to be more common, of course, in people with a family history of Parkinson's. Not everybody with a positive family history has a genetic factor simply because Parkinson's is such a common disease. There's 2 reasons why it's important. The least important is to have yourself tested right now. We tend to be quite reluctant in our center because knowing you have the gene implies that maybe now you want to test your daughter or your sister or your uncle. And if your daughter is tested, if you have a gene and you test your daughter and your daughter has the gene, her next question to you is, Mom, what should I do next? And we don't know because we don't have anything to offer right now. So knowing your genetic makeup is maybe good to know and have definitive certainty which type of Parkinson's you have. But it doesn't mean we know exactly what your prognosis is, because even people with the same gene have very different prognoses. And it may cause a lot of concerns in other family people. Most people who we offer genetic counseling, after they heard the story, decline from being tested. But there is maybe one other reason. We are now beginning to learn that particular genes may affect your response to the treatment. They may even determine your response to deep brain surgery. So the time and era where knowing your genetic makeup is going to affect the type of treatment you're getting is coming closer and closer. That is still part of research today, and I would recommend people with an interest in this to sign up as part of research to help advance the field, but to maybe refrain from testing just for the sake of knowing, unless you feel a burning question inside. I hope that makes sense.
Yeah, thank you very much. And thank you very much for being with us. Unfortunately, we haven't got any time for any more questions, but thank you. You've been amazing. Thank you.